Good evening again, our dear viewers from all over the world. I'm very happy to host with us tonight a very special guest for a very special topic. So, our discussion tonight will be a clinical based discussion in the form of a case based presentation. And this case based presentation will be about an interesting topic, which is the acute aortic syndromes. So I would like to welcome with us tonight Dr. Hazza Omron. She is a consultant of cardiology at Ain Shams University working in the Cardiovascular Academy, and she will present with us a nice case for the acute aortic syndrome immediately after a short introduction that I will be discussing with you about the guidelines and recommendations for this specific topic. So I will start sharing my slide in 1 minute. So most of the data extrapolated for this lecture is from the last update for the acute aortic syndromes guidelines, which was published by the European Society of Cardiology in the year of 2014. So this is the classification of the acute aortic syndromes. As you can see, you have 5 classes: class 1, class 2, class 3, class 4, and class 5. Class 1 is the classic aortic dissection, where you have a true lumen and a false lumen that are not communicating together. You have a total separation of the aorta to a true lumen and a false lumen. Class 2 is the intramural hematoma type, and the class 3 is the discrete aortic dissection with a localized bulging of the aortic wall. The type 4 is actually the penetrating atherosclerotic ulcer, which is caused by a rupture of atheromatous plaque of the aorta. And the type 5 is the traumatic injury or the traumatic aortic dissection, for example, with a femoral artery catheterization using the femoral artery as an axis. And you enter the false lumen with pushing the catheter up. You can strip the aorta, and this is a type of the traumatic aortic dissection, which is class 5. So we have 5 classes of the acute aortic syndrome. Regarding the aortic dissection as one of those, or the most important one, we have two famous classification for the localization of the aortic dissection. We have the DeBakey and we have the Stanford. So the DeBakey type 1, which is Stanford type A, involves the ascending arch and descending dissection. DeBakey type 2, which is still a Stanford type A, involving the ascending aorta only dissection, while DeBakey type 3, which is Stanford type B, involving a localized dissection of the descending aorta distal to the arch. So a Stanford type A will include any dissection involving the ascending aorta. A Stanford type B will include any dissection excluding the ascending aorta, and this is the surgical classification. So any Stanford type A will be dealt by surgery, while any Stanford type B can be dealt medically, endovascularly, or surgery according to the situation. And the Becky type 1 involves the whole aortic dissection. The Becky type 2 localized to the ascending aorta, while the Becky type 3 localized to the descending aorta. So what's the main clinical presentation for a patient with acute aortic dissection? I'm focusing with you here on the first 3 points: the chest pain, the back pain, and the abrupt onset of pain. So those are the most important situations, which is the pain. So the chest pain is found in type A and type B, and as you see, it's 80% of the cases. So it's very difficult to have a painless acute aortic dissection, although It can happen in 20% or less of the cases, but in most of the cases, more than three quarters, chest pain is there. The chest pain will come to the back in 70% of the cases because, as you know, and as we said here, the Stanford type B involves the descending aorta, and this is the part which passes beside the vertebral column. So here, the pain is going to be a back pain. For all situations, the pain is described by abrupt onset of pain rather than building up of pain, which happens with the acute coronary syndrome. The acute coronary syndrome is characterized by building up of the chest pain. You start by minimum pain, and then the pain increases, and then the pain increases with the progressive arterial occlusion. But here, the pain is usually described as a sharp tearing onset of pain. Of course, I would like to highlight that in 10% of the cases, the patient can be presented by an acute STEMI, acute myocardial infarction, if the aortic dissection flap will involve the ostium of the left main or the right coronary artery. So, we have some clinical data which are useful to assess the probability of the acute aortic syndrome as a pre-test probability. And this is important because if you have a patient with a low pretest probability or a low probability for acute aortic syndrome, you will go to perform a test of exclusion for this situation, which is mainly the D dimer test, just like the pulmonary embolism. But if you have a patient with a high risk or a high risk feature, you have the patient with a high probability of acute aortic syndrome, you will not perform a D dimer. You will perform an imaging procedure which will depend upon whether he is hemodynamically stable to perform a CT, for instance, or he's hemodynamically unstable and it's better and easier to perform something like a transesophageal echo. So you're going to have a high risk condition, which will put your patient in a high pretest probability if he has and well known to be a Marfan syndrome, or he has a family history of this particular situation of acute aortic syndrome, aortic dissection, bicuspid aortic valve, Marfan syndrome, Ehlers-Danlos disease, or non-thoracic aortic aneurysm, for example, or he had a previous aortic manipulation, including a cardiac surgery. If this patient also is presenting with a high risk feature of pain, like I said previously, in 80% of the cases, the pain is described by being abrupt onset of severe intensity with ripping or tearing character. So the patient said, I have a sharp, acute onset of pain that is migrating or referring to my back. Of course, you're going to perform your clinical evaluation. And if you find an evidence of perfusion deficit, like a pulsus deficit between the upper limbs and the lower limbs, or between the two upper limbs, or a systolic blood pressure difference between the two upper limbs, or a focal neurological deficit in conjunction with the pain that happened, or an aortic onset and associated with the pain, or the patient is presented by hypotension and shock, those are high risk features in the examination. So here I want to show you that you will perform in the middle of the screen on the D dimer, because the D dimer in the low probability cases, if negative, it excludes aortic dissection and excludes pulmonary embolism. So the D dimer can exclude both of them. While in the high pretest probability, the CT scan is known to be as the triple test because it will diagnose one of three, the aortic dissection or the pulmonary embolism or the acute coronary syndrome if you are performing also the CT coronary angiogram. So here you need to assess by the D-dimer or whether you need to have a conclusive evidence by the imaging procedure. If the patient is stable, you will perform the CT. If the patient is not stable, you can perform the transesophageal echo. And this is the details that you need to know for all situations regarding the intramural hematoma, for the localization of the intramural hematoma, because sometimes you can treat it endovascularly. So you need to know where is it located to choose the type of the covered stent that you're going to use, the extent of the aortic wall thickening at that particular point, because if it is so thin and liable to rupture, you can perform another procedure, the coexistence of the atheroscleromatous disease and the calcium shift and the calcium embolization from the atherosclerotic plaque, and the presence of small intimal tears which can introduce another later on penetrating atherosclerotic ulcer, the localization of the lesion, the length and the depth, and the coexistence with the intramural hematoma, and whether it involved the perivascular tissue associated with bleeding, pseudoaneurysm formation, and the thickness of the residual wall available. In all cases, you need to assess the aorta starting from the aortic valve and down until the aortic bifurcation in the infrarenal aorta. And as you can see here, this is the diagnostic value of the various imaging modalities that are available for the acute aortic syndrome. As you can see that the CT will show you a very good imaging for all the aspects that you need to see, including the ascending aorta and the aortic arch. The transesophageal echo will actually be a little bit low regarding the aortic arch, but it will show you the ascending, it will show you the descending, the size, the thrombus, the hematoma. So it can be used in the emergency situation or the patient is unstable to perform the CT. If the patient is stable, then the MRI wins all because it would be the gold standard for visualization of the aorta, but you need to have a stable patient where you can move him to the CMR lab to perform the procedure. And this is the guidelines. It focuses upon the history and clinical examination, focusing, as I said, on the pre-test probability assessment. So you will choose in the next step whether you perform a test of exclusion, like here in a case of low clinical probability, the D-dimer would be a very good test of exclusion to rule out the diagnosis if it is negative, just like the pulmonary embolism. But in the patients with the high probability having two or three risk factors for the aortic dissection, the testing of the D-dimer is class 3, not recommended. But in the intermediate cases, the D-dimer test could be done in addition to the imaging tests according to the hemodynamic situation and the urgency of the patient. And here comes the guideline recommendation for the imaging. Of course, the transthoracic echo is the initial imaging investigation. If the patient is unstable, the transesophageal echo and the CT are performed according to the local availability and expertise. If the patient is actually stable, then the MRI here is available, is the gold standard. While the transesophageal echo here falls a little bit down because, as I said, it has a little bit poor imaging quality for the arch of the aorta. If you have an initial negative imaging with the persistent suspicion of the acute coronary syndrome, you can repeat the imaging. Actually, it is recommended to repeat the imaging, and maybe in another situation we can show you a case where the initial imaging procedure was normal and one day later the neurological deficit appeared. So we repeated the imaging and the patient appeared actually to have an acute aortic dissection. Of course, the chest x-ray and the widening of the mediastinum is not a gold standard, but it's class 2b. And of course, if you are treating a type B aortic dissection, which is uncomplicated, and you need to follow up the situation, you will need to perform a repeated imaging with the CT or the MRI to see if the dissection is limiting itself and plateauing, or the dissection is actually extending, and you need to perform an endovascular or a surgical procedure. So this is the flow chart. You got a patient with acute chest pain. You are thinking about pulmonary embolism. You are thinking about aortic dissection, and you are thinking about STEMI. So you will take the history and you will perform the ECG. It's a STEMI. You go to another version of the guidelines. It's a pulmonary embolism. You go to another version of the guidelines. So the third diagnosis here would be the acute aortic syndrome. You will look at the hemodynamic situation of the patient. If the hemodynamic situation is unstable, you cannot do an MRI. You perform the regular echo transthoracic, the transesophageal, and CT according to what's available. Confirm your diagnosis, proceed with management, exclude the diagnosis, search for something else. If the hemodynamics of the patient is stable, you will go through the pretest probability. If you have a low pretest probability, you want to exclude the situation, perform the D-dimer, the echo, and the chest X-ray. If it's negative, exclude the diagnosis. If it's positive, you need to perform an imaging. If the imaging is CT, if he's stable, MRI, if he's the CT if he's unstable, the MRI if he's stable, the TEE as an alternative. Either you confirm the diagnosis or you move to another diagnosis. If the pretest probability is actually high, then you perform an imaging procedure directly and you do not perform a D-dimer in this situation. How would you manage the case according to the guidelines? You have a medical, interventional, and surgical pathways. The medical therapy for all patients, pain relief, blood pressure control, and heart rate control. As we know, since we were undergraduate students, you have three things to do: pain, blood pressure, and heart rate. In patients with type A aortic dissection, of course, urgent surgery is recommended. And as we usually say, the mortality rate is 50% in the first 48 hours. So it's 1% increasing mortality with every 1 hour that passes since the diagnosis. So this is a fatal disease. If you have an acute type A with an organ malperfusion, you need to perform a hybrid approach: surgery for the ascending aorta and the arch, and intervention for the rest of the aorta with preservation of the branches, as you know. In the uncomplicated type B, medical therapy is always recommended. If you want to perform a TIVAR should be considered. In complicated type B, the TIVAR is indicated as a class 1 and the surgery is an alternative as a class 2B. What about the intramural hematoma and the penetrating atherosclerotic ulcers? So this is the predictors for intramural hematoma complication: the pain and the recurrence of the pain despite the aggressive medical treatment, the difficult for blood pressure control because this means that the situation will progress because the shear stress forces will continue to cut and dissect through the aortic wall. Involvement of the ascending aorta is a very bad sign because the blood that's coming out from the left ventricle directly shears and stresses against this dissection. Of course, the size of the aortic diameter exceeding a 50 millimeter, the progressive thickness of the wall, which means progressive bleeding inside the wall more than 11 millimeter, the progressively enlarging aortic diameter, the recurrence of the pleural effusion, which is usually hemorrhagic in this case, the penetrating ulcer or ulcer-like projection in a site that was previously known to be a localized dissection, as we said previously, and of course, detection of organ ischemia, whether brain or acute coronary syndrome or bowels or kidney. Management of intramural hematoma, medical therapy, of course, as we said, in all situations of acute aortic syndrome, pain relief, blood pressure control, heart rate control. Type A, urgent surgery. Type B, medical therapy and repetitive imaging in the uncomplicated cases. TIVAR should be considered as a class 2A if complications happen, and surgery is an alternative to the TIVAR. Regarding the penetrating atherosclerotic ulcer, as you see here, it's the same recommendation: control chest pain, control blood pressure, control heart rate medically. Type A, surgery. Type B, complicated or uncomplicated. Complicated, you will perform a TIVAR. Surgery is the alternative. Uncomplicated, medical therapy with repetitive imaging. And this is a case of traumatic aortic injury or contained rupture. Urgent CT is recommended for the diagnosis, localization of the extent of the dissection. If the patient has an acute contained rupture, this is a very high risk for massive fetal bleeding. Urgent repair is recommended. If the anatomy is favorable, expertise available, endovascular using a TIVAR would be preferred over an open surgery. And as we said for the trauma, CT class 1, if not available, transesophageal echo, and if an intervention is needed, as we said, TIVAR should be preferred to surgery. TIVAR is 2A and surgery is 2B. Finally, this is the last slide. Which patients would make a genetic test for the aortic disease because he carries a high risk for aortic aneurysm and aortic dissection? As you know, that first degree relatives, siblings, and parents of a subject with thoracoabdominal aortic disease are needed to identify the familial form, which have a 50% chance of carrying the mutation for the gene, whether it's Marfan, Ehlers-Danlos, bicuspid aortic valve, and so on. Once a familial form of thoracoabdominal aortic disease is suspected, it is recommended to refer the patient to the genetics clinic for family investigation and molecular testing. And of course, every 5 years follow up for the healthy individuals, but those at risk until the diagnosis is established or rules out. And in familial but non-syndromic, I mean they do not have Marfan, they do not have Ehlers-Danlos, but this family has thoracoabdominal aortic disease, you should perform a screening for the aneurysm, as routine screening should be done through the entire arterial tree, including the cerebral arteries, not only the thoracic aorta, as you know, by ultrasound and other procedures. And thank you so much. So we have Dr. Haitham and Dr. Karim with us for the discussion.
So thank you so much, Dr. Muhammad. Hello, Karim. How are you?
Fine. Hello, Haitham. Thank you, Muhammad, for this elegant presentation. Let me ask you a clinical, practical question about the coincidence of acute coronary syndrome in the setting of acute aortic syndrome. How would you manage this patient, and how would you detect the presence of involvement of coronaries in this type of patient?
Yes, Karim, this is a very good question actually, and a very important question. So now we know that for acute coronary syndrome, the transthoracic echo is one of the mandatory investigations to be performed in the emergency room before you move the patient anywhere else, including the cath lab. So you will perform the transthoracic echo. You are searching for aortic root dilatation. You are searching for aortic regurgitation. After you perform a very good clinical evaluation for the pulses deficit and for the unequal blood pressure and all the signs of aortic dissection. The problem is that sometimes the initial presentation, because the coronaries are the first two branches that arise from the ascending aorta immediately after the aortic cusp. So sometimes the dissection is very small, and the first branches to be affected would be the left main or the right coronary artery. I previously had a case of a separate ostia for the left main and the circumflex, and this patient was actually presented by an inferior infarction plus a heart block, and we performed a primary PCI to the patient after performing an echo. The echo showed a mild aortic regurgitation, which can be a finding of no significance or a finding of significance in this particular case. There was no pulsus deficit and everything was equal on the both sides. After we performed the primary PCI procedure to a totally occluded ostium of the circumflex artery, which was arising by separate ostia under the ostium of the left main. So actually, because the ostium of the circumflex here was the earliest ostium to arise, so this was the beginning of the aortic dissection. And then the next day, this patient had something like a TIA. So we performed a transesophageal echo. After we performed a transesophageal echo, we found an aortic dissection involving the big branches arising from the aortic arch. And after we found this one, unluckily enough, the patient was already started on dual antiplatelet because he put a stent in the ostium of the circumflex. And he was delayed from surgery and he did not perform the surgery. So this happens in 10% of the cases. And we saw it a couple or maybe three times during my practice in cardiology. And usually those patients have a very poor prognosis because of the concomitance of the diseases and the obscured clinical presentation while they are presenting to this ER.
Thank you, Muhammad. This is actually a nightmare for every cardiologist to have such a patient. I remember also a patient that's coming with typical chest pain, and I did something simple, which is auscultation of the patient that revealed a murmur, a diastolic murmur over the base. So I also did what you recommended, which is echocardiography that told us that there is a dilatation in the ascending aorta. So we shifted our management from the anticoagulation invasive cryoangiography to the CT angiography, and then we found the large dissection involving the both coronary arteries. So the clinical examination that lead to appropriate imaging and detection of this pathology is very important, as you mentioned. So
Yes, Karim, indeed it is.
let me ask you another issue. You know that prevention is better than cure. So how would you follow up and manage the patient with predisposing that predisposed to acute aortic syndrome, such as Marfan or bicuspid aortic valve?
Yes, for those patients, it's recommended actually, once they are first degree relatives, as you saw here, we'll perform the genetic testing for them, and 50% of those are actually positive for the genetic testing, and they will be referred to the specialized clinic and they will perform the routine investigations, including the echo, including the ultrasound, including the duplex extending up to the cranial vessels, because there is an association also with cerebrovascular aneurysms and intracranial hemorrhages. So those are one category of the patients. The other category of the patients that have the familial actually form of the disease, which but non-syndromic, they are not Marfan's or Ehlers-Danlos, and they have the familial. So those guys who are apparently healthy and asymptomatic will perform also those procedures for diagnosis every 5 years until you find something that shifts your attention, and they have a lower threshold for intervention by 5 millimeters regarding the stable abdominal aortic aneurysm or thoracic aortic aneurysm. They have a 5 millimeter less than the regular population. So it's 50, it's 45. If it's 55, it's 50. They have 5 millimeter less to perform an earlier threshold for intervention in those cases, because actually the simple aortic aneurysm is one of the predisposing factors also for the acute aortic dissection.
Thank you, Muhammad.
Haytham, do you have any comment or question?
Yes, are you hearing me?
Yes, yes.
Okay, so I would like to know your strategy or recommendation in post-traumatic patients or patients coming in accident, especially if they are apparently healthy or apparently normal. Do we fear anything for these patients And
Yes.
accidents, this scenario are very common in Egypt, to have a
Yes.
healthy and apparently healthy individual coming to an accident, and then this patient will suddenly die. So, do you have any recommendation in the management of these
Yes.
patients?
So we have two types of traumatic aortic injury. You have the catheter traumatic aortic injury, the famous one, where you perform the puncture and you push the wire and the catheter upstairs, dissecting all through the aorta. If the interventionalist or the one performing is a little bit nasty in his procedure. So this type, you need to make two things emergently. You perform the CT scan as a baseline and you will follow up your patient. If the patient is stable, then this is a type B aortic dissection. And for type B aortic dissection, you will deal with medically and you will perform the regular imaging procedure as I showed in the slide here. The problem is with the traumatic aortic dissection, example for car accidents. So in those patients that are presenting with car accidents, so let me show you first this one. So this is the traumatic aortic injury. In case of suspicion, the CT is recommended. If it's not available, you perform a TEE, and any case with suitable amateur requiring intervention, the TVAR is preferred to the surgery. And here, with suspected rupture, urgent CT for diagnosis. So this is the patient that you are speaking about the car accident. Either he present unstable, so you expect a rupture. So this patient will perform an urgent CT. And actually for the trauma protocol now, you have what is known as full X-ray, full CT. So the patient will perform a full X-ray to detect any fractures, and he will perform a full CT to detect any bleeding. So if the patient is hemodynamically stable, he will perform a full X-ray, a full CT. If the patient is hemodynamically unstable, you need to select the most urgent procedure before you go inside the OR. So if the patient is a suspected rupture actually, and this is the cause of hemodynamic instability, you will perform the urgent CT angiography. And as you see here, if it is an acute contained rupture, the urgent repair is recommended because usually those patients are stable for 1 or 2 days and then boom, it starts bleeding inside the abdomen or the chest, or you get a massive hemorrhagic effusion or a cardiac tamponade and the patient arrests within less than a couple of hours.
Okay, so you're recommending a low threshold of suspicion in any patient that's coming with car accident, even if he's apparently normal, there is no apparent external trauma, that we have a low threshold of suspicion and perform
CT has to be
CT
done.
to every patient, which is wise.
Yes, yes. In the trauma protocol in most of the hospitals now, the full X-ray and the full CT is part of the routine trauma protocol, even if the patient is stable and speaking with you, especially in some kinds of road traffic accidents, RTAs, motorcycle accident, MCAs, where the patient exhibit what is known as the whiplash injury because of the seat belt, because this kind of motion creates something like a suction effect. And this suction effect is one of the factors that is related to initiating the procedure of the aortic dissection. So actually, if the patient is an RTA or an MCA, so in most of the cases, the routine full body CT is necessary to exclude and early diagnose those kinds of fatal complications.
Okay, and speaking about the protocol to rule out everything at once, is there was a protocol calling the no calling the triple rule out protocol to detect whether this patient has a dissection, an acute coronary syndrome,
For
or
acute chest
pulmonary
pain,
embolism for
or
acute chest
pulmonary
pain.
embolism or acute coronary syndrome. Yes, this is the
Yeah.
triple test. yes, triple test for acute chest pain. It's called the triple rule out. You assess the patient first, whether he is low probability or high probability. If he is low probability, a negative D-dimer excludes pulmonary embolism and aortic dissection. If the patient is high probability, you will perform the triple test. The triple test is the CT with contrast. The CT with contrast will show you the CT pulmonaris, so it will detect the pulmonary embolism. It will show you the CT aortography, so it will detect the aortic dissection. And it will show you the CT coronaries, so it will detect the coronary stenosis.
Okay, thank you so much.
So, Muhammad, I want to ask you about the management of hypertension in patient presenting with acute aortic dissection or acute aortic syndrome. So, what's your recommendation regarding these type of patients? As you know, hypertension and severe hypertension can cause also aortic aneurysm and aortic dissection, and some of these patients presenting with very high levels of blood pressure. So, how you managed these patients clinically, medically, as a preparation for
You need to control, yes. You need to control three things: the pain, because pressure, and raises the heart rate, and this increases the shear stress forces. So number one is control the pain totally. Number two, controlling the blood pressure and the heart rate. The problem here, if you have an organ malperfusion, so you need to balance between the blood pressure and the organ perfusion. So you need to give a medication that will control both the heart rate, because every heartbeat acts like the saw cutting through the wood. So every heartbeat will shear stress and make a cutting through the aortic wall. So you need to control the blood pressure, you need to control the heart rate, and intravenous beta blockers in those cases is the gold standard. Here, you need to keep a blood pressure which is below than 100 systolic, and you keep a heart rate in the range of 60 beats per minute or less.
So,
So I think now it's time to move to Dr. Azza Umran,
agree.
consultant of cardiology at Ain Shams University Cardiovascular Hospital. Hello?
Hi, everybody. Good
And Dr.
evening.
Azza will start sharing her screen now. So please, Dr. Azza, share your screen.
Good evening, everybody. Thanks for letting me
Good
share
evening,
my.
Dr. Azza. Your voice is very clear. We need to see your
Thanks
screen.
for letting me share my case today. I have. Do you hear me?
Yeah, we're hearing you
Hello?
very clear, and we see
Okay.
now, and now we see the slides clear. Go ahead,
Okay.
please.
I have an accidentally discovered surgical emergency at our echo lab. It is about a male patient, 53 years old, smokers, hypertensive on medical treatment. The patient presented to ER as he complained of palpitation, had arterial blood pressure of 160/90. His heart rate was 125, irregular, with average volume. The pulse volume was equal on both sides. Peripheral pulsation was intact. Cardiac examination. His ECG confirmed the diagnosis of AF rhythm. His initial ER echo showed a good systolic function, sclerocalcific aortic valve with no significant systolic gradient, and 2/4 aortic regurg, and no resting segmental wall motion abnormality detected. The patient was put on NOAC in the form of apixaban for oral anticoagulation and beta blocker for rate control, and he was scheduled for transesophageal echo for cardioversion on outpatient clinic basis. Should I continue? Hi.
Yes, please. Yes, please
Okay.
continue.
The TE was performed 10 days later and showed the following. Initially, in the AF patient, we want to assert that there is no left atrial thrombi, especially in the left atrial appendage. So our first image was in the 4-chamber view. We have a good contractility, but apparently a higher degree of aortic regurg than that already was mentioned in the transthoracic echo. We manipulated the view, and we detected more severe form or more severe degree of aortic regurg. Further manipulation revealed dilated ascending aorta, and we got suspected there is a aortic flap. We moved to 120 degree, and we saw the flap as we can see here. And there's a severe. In the short axis, we wanted to try to visualize the coronary ostia, but actually it is a very difficult job. We saw the dissection flap is visible. There is full union, as you can appreciate from the image. The descending aorta shows no dissection flap, and that the aortic arch also was free of flap. As regarding the left atrium, it shows a mild spontaneous echo contrast, and the left atrial appendage was free of thrombi. In the light of this finding, coronary and aortic CT angiography was performed, and it reveals type A aortic dissection. Image, we can see that the left main origin is free, not involved in the dissection. Here in the coronal section, the dissection flap is just above the left main origin. Here for the right coronary ostia, it is free also. And this is a coronal section with the increased slide section to visualize both coronary. The arch was free of flap. Also, the descending aorta has no flap. This is another view that shows the dilated arch, the dilated ascending aorta, and free arch and descending aorta. This is a 3D reconstruction, showed also the dilated ascending aorta. After admission to intensive care unit, the patient was operated upon 3 days later successfully. The patient already was on apixaban, so we had to wait 3 days for the NOAC effect to subside. The patient had an eventful post-operative course. This is the patient after aortic repair. The take-home message is that the acute aortic dissection has a high mortality as well as high rate of misdiagnosis due to frequent atypical presentation. In the International Registry of Aortic Dissection, severe chest pain remains the most common presenting feature in both type A and type B aortic dissection. However, painless aortic dissection is more prevalent among patients suffering from type A dissection than type B. And it is associated with increased mortality. About 6.4% of aortic dissection are painless. Thank you.
Thank you so much, Dr. Azza, for this nice case. I believe this patient was lucky because he had aortic dissection and received anticoagulant, but his course was uneventual at the end. So yes. So regarding the transesophageal echocardiography, let's ask us a practical question. Do you feel comfortable to do a transesophageal echocardiography to a patient with aortic dissection?
It's a quite challenging, especially with the patient's training and everything. But if you have the patient well sedated and perform the procedures very quick and targeted, yeah, it is a safe procedure to perform.
Totally agree, Dr. Azza. Yes. I believe that the sedation is very important in this type of
Sedation is
patients.
a good thing.
Yes, and because as you mentioned, the CT may be not feasible for some reason, such as it's not available, or the patient unstable in the CCU, or the patient had had elevated kidney function. So transvaginal echocardiography here would be a good alternative. So
But I believe that the surgery can't be performed without a CT. As in my procedure, in my TTE procedure, I couldn't exclude that there is a free origin of a coronary. This was only confirmed by the CT.
yes, but I believe if the dissection, we detected the dissection flap high away from the coronaries, this can, in most of cases, exclude the involvement of the coronary ostium within
Of
the
course,
false ileum.
of course.
So another comment regarding the extent of the dissection flap using the transesophageal echo. I believe you agree that the two segments that we want to be able to visualize are the distal segment of the ascending aorta and, of course, the abdominal aorta. Do you agree? Yes.
Of course, we need to ascertain the entry and the extent of the dissection, and if there is another tearing segment or an ulcer that doesn't need to be treated, especially if my patient, in my case, my patient was already on anticoagulation, and we believe that the patient has a form of intramural hematoma that extended after he was put on the oral anticoagulation.
Okay, Dr. Az, I want to ask you something about this critical situation in a patient with aortic regurg and aortic dissection regarding the use of beta blockers.
Okay.
There is a conflict here of interest. We want to decrease the heart rate in order to protect the patient from the shearing stress of the aortic dissection. And on the other hand, decreasing the heart rate will aggravate the aortic regurg. So how do you balance these two opposing factors when using beta blockers in these patients?
I guess the first important step here in the treatment is controlling the blood pressure, as Dr. Muhammad mentioned, and to lower the heart rate. The degree of the aortic regurg will be managed accordingly in the intraoperative room. Putting a small dose of ACE would decrease the degree of aortic regurg. However, the cornerstone of the treatment is lowering the blood pressure and controlling the pain and controlling heart rate. Which will
so this is not a contraindication, and we should not fear of using beta blockers in these patients.
Yes, I believe so.
Because the benefit of decreasing the dissection or the prevention of increasing the dissection overweights the effect of beta blockers on aggravating the aortic regurg. So this is not a contraindication, and we should not fear to use beta blockers in these patients, because the cause of death will always be the extension of the dissection and not the aggravation of aortic regurg.
Of course.
Okay. Do we have any other questions?
So, Dr. Azza, what do you think about the time of incidence of aortic dissection of this patient?
I think, as I mentioned, we believe that the patient had type A intramural hematoma, and in the 10 days between his first presentation with AF and the TE performance, the NOAC accelerated the extension of the hematoma and caused an evident dissection with a dissection flag. Because the patient on the day of examination had a very controlled blood pressure. It couldn't be occurred due to high blood pressure. His blood pressure was controlled actually.
Did he have anemia, Dr. Azza?
No, he was totally asymptomatic.
Yeah.
His lab was all normal. A good renal function. He wasn't convinced even that he has an urgent situation and needed to be treated surgically.
Yeah. I think the decision of cardioversion is this patient saved him actually.
Yes, of course, of course.
Yes. So, Muhammad, being the acute aortic syndrome expert, do you have any comment regarding this case from the guideline? So, Haitham, do you have any more questions?
No, I don't have any more questions for Dr. Azza for this. I want to congratulate her for this elegant and lucky case. This patient was excellently managed, and this step-by-step approach saved his life, as Dr. Karim said. But did you detect by any mean why the hematoma was present from the start? Is it
Mostly
because of
he had
his
yes, he gave history of he gives the history of that his blood pressure 6 months ago was uncontrolled, and he had a long history of about 6 months uncontrolled hypertension. Then he began to be compliant on the medical treatment.
Okay. So
as you mentioned before, we should anticipate and treat the patient strictly, especially the patient who has a very high blood pressure, which is uncontrolled.
Okay, so this is one important issue is to anticipate and detect any possible complication of any cardiovascular disease, especially hypertension and diabetes, in every patient. This is an example of how serious the complications of uncontrolled hypertension could extend in patients, even if they are asymptomatic.
Of course.
So I think if we don't have any other questions, we will wrap up this very elegant and to the point meeting about acute coronary syndrome. Dr. Muhammad showed us how the guidelines suspect, detect, and deal with acute coronary syndromes in a systematic way, which investigation is appropriate for every patient, and the importance and the emerging role of cardiac MRI in these patients, and how to deal with any special situation involving the acute coronary syndromes. And then Dr. Azza elegantly showed us a very, very interesting case about the involvement of uncontrolled hypertension and how it can be very serious and cause very serious complications, presenting with AF but ending with an aortic dissection type A that was dealt with properly, and the patient survived. So I think this will be the end of our meeting today. We thank Dr. Azza for this perfect case and perfect illustration of the case, and of course my dear friend Dr. Muhammad for this dazzling illustration of the guidelines. And we are waiting for you at CEC the next Thursday for more interesting topics. And thank you so much. Dr. Karim and Dr. Muhammad and Dr. Azza, do you have any final comments?
Thank you. Thank you for giving me the chance to be with you tonight.
Thank you so much. Dr. Karim. Okay, so we conclude the session, and thank you so much for being with us, all our fellows. Thank you so much.